Good afternoon, participants of the Kenya Renal Association at the Pride Inn, Sanzu. I know that you're all enjoying yourself. I wish I was there with you. Hopefully next year I will be there with you. So today I'm going to present a lecture on AKI in children with Misconverting seen at Gertrude's Children's Hospital, Nairobi, Kenya, between 2021 August up to 2021 September. And my team consists of the following two infectious disease doctors and intensivists, and also one of our students, Emo, who has greatly assisted in putting this paper together. So the first report of this mysterious disease was in 2020. It was reported from the UK and was seen in children in the UK, reported in the Lancet. And they reported a disease that presents in children similar to incomplete Kawasaki or toxic shock syndrome. Later, cases were seen in New York, reported in the New York Journal of Medicine in 2020. Then various cases have been seen since then. So this is one of the articles in the New England Journal of Medicine. And they were actually doing a surveillance study for this mysterious new disease that was occurring in children. Multi-system inflammatory syndrome in children is usually mild, but sometimes children can be very severely affected. Clinical manifestations may differ from adults, and in children, it is an uncommon complication of COVID-19. Can present as Kawasaki's disease or toxic shock syndrome. The epidemiology of this disease is that it can occur from any age, infancy to late adolescence, and occurs in previously healthy children, ages 6 to 12 years, although it can occur in others. And Black and Hispanic children are more affected. And this disease peaks several weeks after surges of COVID-19 in the community. The incidence of this disease in children is about 2 per 100, as shown in the reference paper shown below. So now I'm going to present some of the work that we did in Gertrude's during that time, that is September 2020 to up to August 2021. We had 6 cases as shown below, and the ages varied from 7 years up to 15 years. The mean age was 10.8. All of them were males, and the date of admissions are as shown below. So the initial complaints are as shown below: fever seen in all of them, anorexia seen in all of them, no sore throat, no pain and swelling 2 out of 6. None had cough initially, and none had shortness of breathing initially, but later on it was there. Abdominal pain was the chief presenting symptom. It was seen in all of them. Vomiting was also seen in all of them, and half of them. Passage of loose stools seen in about 4 out of 6. Some presented with headaches. Dizziness was seen in about 1/3 of the cases. Altered mental status was seen in half of the cases. Slurred speech, was seen in about 50% of the cases, and there were no convulsions. So this other table just shows you the presenting symptoms that they had, presenting signs, And you can see, if you look at the initial blood pressure, that they all were hypotensive. They presented with low blood pressures, 76/47, even 62/30, and so on. And this was seen in 100% of them. And then the most striking thing was the severe dehydration that they came with. So as you can see, fever seen in all of them. Rash was only seen in one, and this one was of Asian origin, one case. It turned out to be Kawasaki's, because Kawasaki is actually seen as Miscovid in the people from the Far East. So then there was lymphadenopathy. Sorry, this should be 1 out of 6, should be 16%. Dehydration, as I said, seen in all of them, shock in all of them, and there were other things like abdominal pains. And so some of them, actually, we had to call in a surgeon thinking it's acute appendicitis, whereas it was not. So the laboratory results, urea electrolytes, creatinine, is important to see this. If you look at the sodium, you can see that many of them initially presented with hyponatremia. You can see that across the, sorry, you can see that across where sodium is written. They had hyponatremia, and we had to correct for hyponatremia. And then some of them, maybe 4 out of 6, presented with features of elevated urea, as you can see that. And they also, the same who had elevated urea, had also slightly elevated creatinines. I think the highest was 421. And you can see that the one with Kawasaki, that is case 5, actually did not go into renal failure. The EGFR was also reduced, apart from case number 1. So these were the COVID PCR and COVID-19 antibody tests. And you can see that in all of them, the COVID PCR was negative, but the antibody test was positive. The IgG especially was positive in some of them, and also the IgM was positive in a few of them. When we look at the inflammatory markers, we see that the inflammatory markers were actually elevated in the majority of them. Ferritin was high, LDH was high, CRP, procalcitonin, ESR was high. Then now we come to the enzymes that indicate cardiac damage, that is the troponin. In those that it was done, it was high. And then there's the bone natriuretic peptide, which you only did in 2 of them, and it was high. Creatinine kinase was also high in the few that it was done. So this actually is just a summary of the inflammatory markers that were done. And you can see, even though we did in 5 out of 5, in those 5, it was 100%. LDH, 4 out of 4, 100%. And you can see the trophin levels where they were done were high in all those that it was done. COVID, I think I talked about it before. The PCR negative in all of them, the IgG positive in 5 out of 6, IgM positive in 2 out of 6. Then we had radiological findings. We had pleural effusion in about 50% of the patients, and there were opacities in the lungs, about 50% of the patients. Enlarged, when echo was done, enlarged coronaries, dilated coronaries, was only seen in the one who had an atypical Kawasaki. But in the others, all the others, there was mild mitral valve regurgitation, mild tricuspid regurgitation, reduced ejection fraction, and pericardial effusion in 1. Renal ultrasound was done only in about 3 of them, and we saw increased parenchymal echogenicity and ascites. So how did we manage these cases of COVID-19? What missed COVID-19? Immediately they arrived at the emergency, they were diagnosed with shock, and most people thought it was bacterial shock. And so there they have been trained in advanced life support. And so they resuscitated immediately with normal saline policies. And then IV fluids were started for the dehydration. When they went into the ICU or HDU, the hyponatremia was corrected, so was the hypokalemia. One, that is the Kawasaki, had hypomagnesia, it was corrected. And if there was a low calcium, it was corrected. Out of the 6, all of them needed to have albumin infusion because the albumins at some point along the way became low and they developed pedal edema. They had like a shock that was refractory to fluid. So in about 5 or 6 of them, we had to use adrenaline, and inotropes and norepinephrine had to be used in 4 out of 6 because they were really hypotensive. So half of them had to have blood transfusions, and 2 out of 6 had to have FFPs. As I've said, albumin had to be given. Now, along the way, once they got out of the shock, several days along the way, then we found that actually they had developed fluid overload, and some even had gone into a bit of pulmonary edema. And so we had to use diuretics. We used furosemide, and in some cases, we caused diuresis with aminophylline. And those who are in CCF, spirolactin was added. Antibiotics, various antibiotics was added to all of these. Because of their very high septic markers, we ended up using meropenem and vancomycin in about half of them. So anticoagulants was given, that is Clexane, to the 5 out of 6. That is 83.3%. So then immunoglobulins was given to 5 out of 6 of the patients, that is 83.3%. And then methylprednisolone, they were paused for 2-3 days, and this was done so in 5 out of the 6 patients. Aspirin, high dose aspirin was only used in the one who presented with features of Kawasaki. One of our patients was on developed antihypertensive because of the high steroids. After the methylprednisolone, we gave them prednisone. So this one developed hypertension, and he had to be given amlodipine. Esomeprazole was used in all of them. So this is summary of the results. The incidence of fever, gastrointestinal symptoms was seen in all of them. Features of Kawasaki's disease was only seen in 1. And then cardiac damage, coronary artery dilatation, seen in the 1 case who had Kawasaki. Things like pleural effusion, pericardial effusion, myocarditis, cardiac reduced systolic function was seen in 5 out of the 6 cases. High troponin levels indicating cardiac damage or cardiac damage was done in 4 cases, and in all of them it was high. Then there was things like reduced lymphocytes, thrombocytopenia, and all that. And this was seen in about all the cases, 100% at some point in their stay. Organ injury was seen, liver dysfunction, seen in about 4 out of the 6 cases. All the 6 cases at some point had some level of either fluid retention or electrolyte dysfunction. And so it was seen in all of them. Not necessarily, as I said, there's one who didn't actually have elevated urea or creatinine, but he had fluid retention. And lung disease was seen at some point, not initially, but at some point along their stay, was seen in about 100% of the cases. 2 of the patients had to have mechanical ventilation. For the others, they just had to have oxygen by nasal prongs or non-invasive methods. So how long did they stay in the hospital? So you can see that one stayed quite a long time, 25 days, but the others actually on average did not stay more than a week. The stay in the ICU was probably the longest because this disease is actually very terrifying. When you see it, these kids are really, really sick. And so they stayed in the ICU for the days that you see there. Out of this 6 cases, 5 have been seen and they're doing very well, but 1 has not been seen, lost to follow-up. So now we are going to have a little discussion about Misconverting in children. And how do you define this case? So there's the CDC Differentiation Criteria, and there's also the WHO criteria. I prefer the WHO criteria, which says that all 6 of these points listed here must be met. The age must be less than 20 years. Fever must be there for more than 3 days. And there must be clinical signs of multisystem involvement, for example, rash, conjunctivitis, which we saw in about 3 of our patients, and then hypotension or shock, which we saw in all our patients. Then there should be multi-organ involvement, cardiac dysfunction, and evidence of coagulopathy, acute GI symptoms, diarrhea, vomiting, seen in all our patients, and then elevated markers of inflammation seen in all of our patients. And then there should be no obvious microbial causes of inflammation. There should be evidence of SARS infection. So either a positive PCR or even a negative one as seen in our cases, and positive serologies of COVID as was seen in our patients. And some of them had a history of post-exposure. However, many of them came from boarding schools, and they said that some of the children there had colds. So what is the clinical spectrum of COVID-19? This one, it's very mild when you have the acute COVID-19. It's mild in most children, but in a small minority of children, it can be quite severe. And you can have respiratory failure, ARDS, neurological symptoms, coagulopathy, shock, and so on. Then you have the COVID-19 associated Misconverting syndrome, where you have a febrile inflammatory state. And so these children may present with persistent features, headaches, fatigue, and inflammatory markers may be elevated, but signs of multi-severe system involvement are lacking. And in the hospital where I work with, we are actually seeing a big number of these, but they do not end up in the HDU because they are not in shock. And some, like the one case that I showed you, can present with the Kawasaki-like syndrome, okay? Then we have the severe ones, and this is the group that actually I've been talking about. They're the ones who ended up in our PICU, and these are the children who present with severe Misconverting, and they have markedly elevated inflammatory markers and severe multisystem involvement. What is the pathogenesis of acute kidney disease? It may be secondary to abnormal immune response. And what happens is that it causes, this virus causes tubular injury. It causes podocytopathy, renal inflammatory process, hemodynamic instability, and vascular endothelial dysfunction. So the pathogenesis of AKI in this disease is that it can affect the kidney directly. The spike S of the virus, glycoprotein, they bind to the ASE2 receptors on the host cells, that is in the tubules, renal tubules. And then the active X protein is cleaved by transmembrane cerebrase protease. And this results in membrane fusion facilitated by viral fusion peptides. Then the virus penetrates the proximal tubule and the podocytes and causes the renal damage. So this is a graphic representation of what I have mentioned. You can go through it in your own time. There's the RAS activation, that's the first stage. Then there's the cytokine storm, and you cause a hyperimmune response and inflammation. And this is what causes the renal injury and causes the hypoperfusion, vasoconstriction, and renal dysfunction. And then there's the endothelial dysfunction, where there's complement activation, coagulation activation, causing an inflammation in the capillaries, in the blood vessels, and also thrombosis and then the capillaries are obstructed with red blood cells. This leads to ischemic glomerular disease, fibrin necrosis, and AKI. What is a differential diagnosis of suspected MIS-COVID in children? The first one is Kawasaki's disease, and then you also have to think of severe COVID-19 infection. Bacterial sepsis, this is the first one that we think about in our casualties when we see these people. Toxic shock syndrome, appendicitis. So many of our children presenting with abdominal pain, we actually invited the surgeons and they ruled out appendicitis. Other viral infections, such as Epstein-Barr, cytomegalic virus, adenovirus, and so on. Other infections, well, we thought about malaria in all of them, and we ruled out malaria. And then there are other conditions like SLE and vasculitis. So these following slides, my references have come from these two references that you see there. So now, when these patients present to us, what we have to do is to say, do they have severe manifestations? And do we suspect MIS-COVID disease? If they meet this criteria, then we go ahead and do all these things. We do a complete blood count, we do urea electrolytes, liver function test, we do the cardiac markers, blood cultures, blood gases, and then we do markers of inflammation like CRP, and procalcitonin, D-dimers, and so on. And of course, the serology must be done for COVID, PCR, for the antibodies, and also for PCR, COVID. Then we also do other panels to look as a biofire if we can't look at the respiratory biofires, and so on. Chest X-ray is very important. Abdominal ultrasound is also important because you want to see whether there's any enteritis, colitis, or renal involvement or hepatic involvement. Then you should, of course, connect them to the ECG. Echo is mandatory for all our patients. Then, and monitoring with ACG. And then these children need to be managed by a multidisciplinary team, as was in our case. These are the intensivists, the cardiologists, rheumatologists, infectious disease, and of course, in our case, nephrologists. Then from there, if they don't have, they don't meet this criteria, then you can look at the column on the right-hand side. It will tell you what you need to do. So how do you manage them? So as I said, if they're in shock, you must immediately manage that shock with fluid resuscitation, boluses of normal saline, and then putting them on the, correcting their dehydration. And then if they require, and all our patients required, adrenaline and noradrenaline, you must give it to them. Now, then the specific treatment is that they are given IVIG, that is immunoglobulin, 2 grams per kg. If you suspect Kawasaki's, then you must give them high-dose Septrin. As I say, only one of our cases was given. And we gave our cases, all of them, methylprednisolone, about 10 to 12 milligrams per kg IV for 3 days. They were pulsed. Then we followed it with oral prednisone, just for, and tapered it off. You can see that here there are other third therapies that can be given. We did not get to that level of using the third therapy, anakinaren. Now, okay. Sometimes if they are very, very sick, then you may require to dialyze them, which we didn't require to dialyze. And you may even require to use to do plasmapheresis, and we didn't have to do plasmapheresis in our case. So some of these patients will recover, and you are lucky, with just correction of the dehydration and electrolyte correction. This is if they have kidney involvement. Remembering that at this time, when all this is happening, the intensivists are taking care of their respiratory system, giving mechanical ventilation where it is required, and providing oxygen and other things where it's required. So kidney replacement therapy may have to be done in those who are very, very severely sick. And in this case, peritoneal dialysis, hemodialysis can be used. Of course, the best one for removing fluid overload is CRRT. So in conclusion, we say that these cases of misCOVID in children requires a very high index of suspicion because you may misdiagnose it or even miss it. It is a life-threatening disease. It requires immediate fluid resuscitation of the presenting shock status, and that a multidisciplinary team requires to handle this case, and it should really be done in a place where you've got ICU settings or HDU settings. And there needs to be appropriate management of respiratory, hemodynamics, and multi-organ manifestations. Severe cases may require inotropes, IVIG, and methylprednisolone therapy. If managed correctly, prognosis is favorable. Thank you for your attention.